Our next case is a 47-year-old patient who developed acute necrotizing pancreatitis of unknown origin. 2 months ago, CT abdo and pelvis showed acute pancreatitis, and CRP at 72 hours was 280. As we see in the CT scan. So 1 month later, she presented with vomiting and epigastric pain and CRP 9. CT scan at that time showed large pancreatic pseudocyst, 17-11 by 6 centimeter. So decision was made to do an EUS guided cystogastrostomy with Dr. Geoffroy Van Bervelde and Dr. Yasser Shaib.
So for this last case in this room, we will insert lumen opposing metallic stent to perform this cystogastrostomy, because as you can observe on the US image, it is a huge collection of more 10 centimeters with a lot of debris inside, and maybe half part of the collection or 2/3 of the collection is formed by debris and necrosis. And in this situation, we know that even if there is no infected necrosis, there is a relatively high risk that we have to perform necrosectomy and endoscopic necrosectomy in the future. And to do that, the best is to have a great access, and the best access you can have, it is using a lumen opposing metallic stent. So here we will use the hot axios platform that you already know from many years now, and we will try to perform an access using the hands-free direct procedure, which means that we don't use any needles before, any guide wire, and we go inside the collection, which is very large, in first intention. So you can.
So what are the criteria for you to perform this? What will prevent you from doing it today?
So we perform the procedure because the patient is presenting nausea and gastric outlet obstruction, a partially gastric outlet obstruction. It is one of the main indication with the infected necrosis. It could be biliary obstruction also.
Right.
It could be refractory pain. And of course, the hemodynamic instability for patient in intensive care after the first acute episode of pancreatitis. Here it is due to pain associated with nausea and vomiting. And in the future maybe nutritional impact that we have to avoid to allow a better scare of the recovery of the pancreatitis. So the advice we can do is to go inside in AutoCut setting using the RB processor. So because you have to go inside the collection very quickly, and for that you don't have to use the current after push the catheter. You have to first do the electrocoagulation current and then push the system. Like this, you are inside very easily and rapidly. Most of the time, best is with this used collection to push a lot the platform and the catheter of the platform inside the collection, because there is no risk of damage of the posterior wall of the collection.
So you're saying you push as much as you can if you have the space.
Absolutely, absolutely. So you see very well the catheter inside the collection. It is sufficient. So you will deploy the distal flange. So it is a 20 millimeters stent.
And as you can see, the endoscopist is handling the whole procedure.
Yes, for the assistant, it is very easy. So now there is two possibilities. The first one is to launch the proximal flange inside the working channel of the scope. Personally, I prefer to launch and to deploy the proximal flange under endoscopic view. But it is because I am from an old fashion. And
That's always that's a big issue, because for old-fashioned endoscopists, you're not used to deploying stents without seeing. So it's a new approach that we have to get used to.
So you have to insufflate. Sometimes it is not so easy, but you have to insufflate.
So we have a question here.
Yes.
Would you try to aspirate first for culture, or
So you can do that, but after deploying the system. It is not possible to do.
through this?
Yes.
No, we'll aspirate after he opens. So.
Okay. So you have to take your time just to be sure that you are in place to retrieve the stent. Okay, so here we have a great view of the catheter.
And what are you?
You just have to pull a little the catheter to observe the black ring, which is here. When you have the vision of the black ring, you can deploy the proximal flange.
And how do you handle your scope now after? Okay, so you just look away.
Yes. Alors, this was very interesting because you can see that the catheter was completely inside the collection. So I just prefer to perform a rotation with the handle just to push the flange inside the gastric lumen. So this is the rotation movement which allows
collection cup.
And after that, you retrieve the catheter, and now you can use a single channel catheter if you want to perform a sample for the bacteriological analysis and so on.
Oh.
So if you want, yes, if you have a catheter, a single catheter to perform a bacteriological analysis, it is possible. So you see that.
Just get a catheter. Yeah.
And you can see that the liquid seems to be clear.
It seems clear and
Yes,
not
yes.
infected, but we're going to use a balloon here. That's what we have.
Yes.
That works. Yeah, so anything that you can aspirate with.
Okay.
Would you dilate now?
No, never.
Why?
I think it is not necessary because it is not mandatory because finally in 24 hours the stent will be completely deployed spontaneously, and when you want to dilate it, the channel of the stent. This is in this case that we have misdeployment or dislodgement of the stent. So I'd never take the risk.
Even if you're doing a necrosectomy.
Yes. Yes, because try to aspirate maybe. Yes, because the rare case I have performed that it was yes, it was unstable hemodynamic patient with.
Just move
yes,
it.
Yes, yes. So put you here. Yes.
Down. Move it more.
Not so easy.
Okay, they're. I think they have to go to another room.
Okay,
We're gonna aspirate
bye-bye.
some fluid for bacteriology.
Yes.
If you move it, it's better. Our next case is a 93 male patient with a past history of hypothyroidism, diabetes, and hypertension. He presented with jaundice and recurrent abdominal pain. Here, as we see, the MRCP showed over-distended gallbladder that contains multiple stones with a marked intra and extrahepatic biliary ductal dilatation. So ARCP was done, a large sphincterotomy was carried out, and extraction of a huge number of CBD stones of different sizes until clearance of the CBD. After that, a plastic stent was inserted. Here, as we see in the video, the stones that were removed from the CBD. So the patient still suffers from recurrent biliary colics, and he is unfit for surgery. So the best decision for him is to do EUS-guided cholecystoduodenostomy, which will be done by Dr. Marc Barté.
Yeah? I am online. Okay. So please to try to finish this remarkable day for live presentation. So we are facing with a very old man, 93 years old, and so we have not so much time to discuss, but I will show you. We decided, as this patient has already a biliary stent, and I checked the bile duct, the CBD with EUS. He has no more stones in the CBD, but he has, of course, some air due to the biliary sphincterotomy and the stent. You see he has still some symptoms due to his gallbladder. So you see the gallbladder, I hope you have the US image, and you see the gallbladder, the gallbladder wall is not so thick, so this is not a case of cholecystitis. This is a case of symptomatic gallbladder with gallstones after biliary sphincterotomy. This is about 20% of the cases of patients with biliary sphincterotomy and gallbladder with stones let in place have, in 20% of the cases, symptoms. So you have to do something to the gallbladder. And here we plan, give me the stent, please. So we try to discuss between doing transpapillary cyst gallbladder drainage, or to do percutaneous approach, or to do EUS-guided gallbladder drainage. And finally, we decided to do the gallbladder drainage because it's very old, and we have to have a final solution and with the less risk which is possible. So I'm just trying to fix, okay, on it. Okay, now it's much better. Okay, you see clearly the gallbladder here with some sediment and some small stones. And so you see, I will push my axial stent, my lamp stent. You see the sheath, okay? You don't push too much, okay? I am connected, and I'm using pure cutting current, you see? So just I apply, maybe you can see X-ray, okay? X-ray, and now I just apply, and you see I'm inside, and you have to go a little bit deep, because if not, you have a risk of releasing the distal flange between the gallbladder and the duodenum, which would be a disaster. I just push a little bit. No, my God, why? No, it wasn't possible. So now I close, and I will release the distal flange, and you will see. Okay, this is the release of the distal flange. You see it now? Okay, so I will pull back a little bit Okay, you disconnect. Okay, okay. And now I will move to the endoscopic part. I hope you have the endoscopy, you see? Okay.
So you also prefer to do it endoscopic?
Yeah, yeah. In this case, yes. Yeah. Yes. Because we started with Geoffroy in the school of X Lumina before having the hot Axios, okay? So now I will go very fast, okay? And I will release, okay? Okay. And now, normally it's released. Yeah. Okay. Okay. So I will push a little bit my guide wire inside in case of any troubles. You see clearly the stent now, and you see the pus flowing out into the duodenum. Okay. Okay. So now I move to the complete endoscopic image. Okay. And now the goal is to retrieve the device, letting in place the guide wire. Okay. Okay. So Al, you agree? So we are going to check with. Okay. You see the guide wire is into the gallbladder. Push the guide wire, please, gently. Okay. Okay. You see. Okay. Push it more. Okay. This is a lamb stent. It is a 15 mm one. So normally the diameter for draining the gallbladder is ranging between 10 to 15 mm, depending on the wall of the gallbladder. In this case, it was nearly a normal gallbladder wall because it was not a cholecystitis. Huh? So this is the endoscopic part, okay? And now I will try to put over the guide wire a double PTL stent. Why? Because we have a risk of obstruction. Yeah. I saw that. You think we are useful? Okay. And why trying to insert a double PTL stent? This is to try to avoid obstruction of the stent with the stones. Okay. So this is not well demonstrated. You know that for choledochoduodenostomy, we have a randomized study going on in Spain, which is called the BAMPI study. This is probable, but not sure, okay? But as this man is a 94-year-old man, I don't want to take any risk, and so I prefer to try to do that. Okay? So you see the hand of the nurse, who is working very well. I'll thank you very much for you. Okay. And the guide wire was only preloaded. Huh? I didn't insert. This is a West technique, huh? The wireless, because I entered into the gallbladder lumen without using any guide wire. Okay. Pull back a little. Sorry, pull back a little bit the guide wire. More. Okay. Now I'm entering inside. You see, I just changed my position. Okay. Okay. So I think now you can release the guide wire. Okay. 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 And I'll go back a little bit. Okay. This is done. This is finished, you see? It's okay for you? So you see, this is a 93-year-old patient, so we have to go fast and to be safe, the more safe we can. I think we were safe, and I hope this patient will be better. Thank you very much for your attention. Thank you.
Okay, so now with the third case of our LIVE4, a 67 years old patient known to have hypothyroidism, diabetes, dyslipidemia, and hypertension. She has a rectal LST polypoid lesion of 3.5 centimeter, Paris 1S 2A with nice 2. EUS was done, showed no muscular invasion, UT1. So now for re-evaluation and DSD, which will be done by Dr. Gabriel Rahme and Dr. Mahmoud Halal.
Okay. Hi again, everybody. We are very happy to work here together. And this is a case of a rectal lateral spreading tumor, granular type. And I would like, we performed the circumferential incision of the lesion. We analyzed the lesion. There is a fibrotic area just in front of us. That's why there is really, I don't know, biopsies, previous EMR. But I will show you that using this traction, perhaps we can make this part easier. Then I will grasp the specimen just here. Open, please, and close. Close. Okay. I think it's okay. Oh, yes. Open. Sorry. Yes. Yes. Sorry. That's I see. Yes. Okay. I just. Okay. Close. 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 Okay. Then I will try again. Open and close. Close. I think it's okay. Yes. Okay, everybody say yes in the room.
Yes.
Clip. Okay. Thank you. Then we discussed the case just before, and we think that it's nice to clip just here in the oral site, just here in at the top. Of course, you can also clip in the anal site, but I think it's not a really big lesion. We can just clip just above in there. We are in. There is it's quite bleeding, and there is this fibrotic part in the anal site, which is quite difficult to make for the dissection. Open, please. Okay. Close.
Okay.
Okay. Now I will just make a target, exsufflate, not pushing too much because to have no injury in the lesion. Exsufflate, exsufflate. And I think that here it could be nice. Open. And close. Okay. Okay, I think it's quite nice.
Okay, it's good.
Okay, thank you. Now we can make more insufflation. And you see, this is a fibrotic area, and the traction probably will help me to find the lining cut. I will inject just with the needle before the clip. I made the circumferential incision, and I make just okay. You can see here probably it's. If I inject here, there is some. Okay, you can see on the right the submucosal layer, and on the left. There is big vessels because we are in the rectal case. Okay, out. I use forced coag, effect 4. We can see very well, or not so well, but we can see the muscle. Yes. Okay, this is a muscle. Okay, for the incision, I use the undercut mode, undercut section. Yes, there is some fibrotic area. That's why I use here soft. I change. Be careful in. Okay, just to inject with this knife, you have to put the knife in. Be careful with the... Okay, we can see here very well the fibrotic area out. And because it's fibrotic, you can see I use the undercut section. Be careful because it's you can have bleeding if you use too much undercut mode, but it works very well. Okay. Then I use a gastroscope, Fujifilm 700 series. We make the characterization just before, and there was no sign of invasive cancer and deeper invasive cancer. Probably there is only adenoma, but because of the fibrotic area, the dissection, and because of the granular part more than 1 centimeter, we have a risk of a tumor cell inside the lesion. Alors, what about, we can discuss the indication of EMR in this case. I think that if you cannot perform ESD, of course you have to discuss EMR, I think, because we did not have any suspicious, invasion part. But if you are trained in an ESD, of course, I recommend the ESD technique. I again switch for soft coagulation, and I try to always make the coagulation during all the procedure. Not to wait and to say, okay, I will do the hemostasis after. No, we have to do the hemostasis during the procedure and step by step. Also, I use my knife, the flush knife, which is an injection knife. It's the length of the tip is 1.5. As you can see, I use a lot of undercut current because it's quite fibrotic. You always have to know where is the muscle. Okay? Okay, I can pull back. I see the muscle is here, white. I can inject here, please in. I push inside, and I can see better the layer, the submucosal layer. Okay. Then I use a cap. The name of this cap is the top, TOP. It's quite convenient because the field of view is it's quite nice. You can see very well the image, endoscopic image. Yes, out, please. You can see on the left part a vessel. Donc you have to be careful. And try, don't try, look at this vessel. You can see the muscle just here, the vessel here. You have to grasp from the right. I put the soft coagulation. I am in soft coagulation mode on the right and from the left. After that, I inject more in, please. Okay. Out. Okay, we can see very well this vessel. Out. Thank you. As I can. Yes, you can see here that I can grasp it. You see? Yes. And it's really important to grasp it near the muscle layer. Out. After coagulation, I switch. I am in forced coagulation. Up. You see? In. Exactly, probably out, of course. Probably I will need a coag grasper because it's a vessel from the muscle. Okay, I'll take the coag grasper and I will show you how to use the coag grasper. The coag grasper is a hot forceps biopsy. Of course, you can use coag grasper, or if you have hot forceps, it works also very well. The first thing to do is to open in front, open, to grasp the vessel. Okay, close, to wash. Okay, stop the bleeding. I am in soft coagulation. And okay, open again. I think it's quite okay. Close. And I use a soft open. Okay. There are so many vessels. Close. Open. Close. Open. I think it's quite nice. I can use the underwater vision just to check. I just want to, because I have the coag grasper in place, don't want to, there is probably a vessel somewhere. Open, close, open, close. Bon, okay. Then, okay. Open, close, no, open, sorry. Close. Open. Okay, I don't want to say okay, but open again, close. Okay, open and close. No, I don't want to say okay. Remove, please. Thank you. Then I just make some aspiration. I hope we are confident. Then you see that the clip helped me with this knife. If you want to make some suction, better suction, you have to push the knife 10 centimeters, and there is an operating channel quite efficient to make suction, as you can see now. And after suction, I think we can continue now. Then perhaps we can work on the right here. Out. Yes, I use in this case saline solution to have. It's really important to have the current for the knife, and sometimes it doesn't work with only water. Okay. In. Out. Okay, soft coag. Yes, 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 exactly. Okay, and now we can continue. Okay. It's really fibrotic and also bleeding. I put more insufflation. You can see the vessel. It's quite difficult to isolate the vessel because you are multiple vessels, exactly. Okay, be careful. This is in. This is a submucosal layer out. We can see very well the vessels. I don't want to touch the vessel. Okay, I switch, soft. Okay, forced. Okay. It's really tricky. I have to stop to say okay, as Marc say. Perhaps I have to take the coag grasper. No. Okay, no need. Perfect. And sometimes it's more difficult to see the vessel when you have fibrotic area. Yes, fibrosis in.
Is there a risk of delay bleeding when you coagulate the vessels?
Yes, the risk factor for delay bleeding are mostly right colon, large lesion more than 3 or 4 centimeter, and anticoagulant out, and anticoagulant or antiplatelet drugs, and some comorbidities. Then perhaps I have to ask, in this case, if the patient has anticoagulant. I don't know, but it's a really important question. We can ask. Bleeding. No, okay, thank you. We have the information. Where is... Okay, then probably I have to take the coag grasper.
Grasper?
Okay, yeah. Grasper, yes. Coming from muscle, yes. Probably I have to take a coag grasper. Thank you. Thank you very much, yes. Okay. Oh. Just above the muscle and intermuscular, if you can. It's a new way, the intermuscular technique. It works very well. We can see the vessel just in front. Open. Sorry. Sorry. Close. Excellent. You see, it's quite, yeah, it stopped the bleeding. I am in soft coagulation, yes. And apply the current. Okay, open. Perfect. I just want to see if there is other vessel like here, you see? Close. Open. I will grasp a little bit. Oh, we can.
Yes, this one.
Okay, close, excellent. You have to wait for the changement of color, and you have to obtain this whitish color. Open, close, close, thank you. Okay, open, close. So, underwater, it works also really nicely. Open, close. Of course, if you have this kind of lesion, open, bleeding and fibrotic lesion, of course, it's a longer procedure time. Unexpected, close, but that's why for the beginners, I recommend open to take your time. Open, open. Thank you. Are you with me? Are you with me? Okay, now I think we can continue. Then, if you plan to begin with the rectal case, of course, it's probably safer than the esophageal case. I totally agree. But because of this kind of, bleeding and some fibrotic, not so much, but also bleeding probably, take your time and discuss with the anesthesiologist. You have to work with the trained help endoscopists, as here. It's perfect because they used to do this kind of technique in this unit. Out. Exactly. We can see the. Oh my God. You can see here the okay, this vessel.
Okay.
No, it's not okay.
Bye.
It's not okay because it's the vessel comes from the muscle. That's why. And I don't want to take my coagrasper, but sometimes you are in mind, I don't want to take the coagrasper, and you lose time. Then sometimes you have to take the coagrasper out. Okay, we can continue now until the next bleeding. And of course, because I use a lot of undercut current, there is less prevention of coagulation. You can see here. Yes, we arrive on the back side, exactly. Exactly. Oh, soft, you can see the vessel very nicely. Then I make my soft coagulation and I grasp with the ball tip and I make the hemostasis. Okay. Okay. Then you can see here the famous submucosal layer is just in front of me and the muscle is just below. Okay, here I stop. Probably I switch and bleeding. Okay, here. If you succeed to prevent bleeding, you gain a lot of time. And the opposite, of course, you lose precious time because we are there is a... Yes. We cannot. It's really, really difficult. And, sometimes when you have some whitish part invading the muscle, you can see sometimes, oh, you can see the vessel. You can, but we are sometimes surprised. Out, please. Excellent. I switch for soft. Okay, out. I switch. I use the first coag. But even the first coag, yes, doesn't work very well. Okay. Okay. We can see the edge. You can see the edge, the mucosa. It helps to say, okay, you have to go on the right or on the left. Okay, I make some section just to see very well. You have to take your time. This is the procedure, ESD. You have to be really patient. We use CO2 insufflation.
Is there a risk of stricturing?
Sorry.
Stricture?
The stricture in the rectal location, it's not so frequent. You have to probably make a huge resection with a scar, more than 3/3, probably entire circumferential. Then you will have, yes. It's not the same case for the esophageal lesion. When you have more than 2/3 of the circumferential, you will have a increased risk of stenosis. Okay, you see, take my time. And don't forget that the vessels are in the upper part of the mucosa. Ah, yes. Okay, thank you. Then the vessels are in the upper part of the submucosal layer. And then it's not a good case to see that because there is fibrosis. But you have to cut just above the muscle and under the vessels. Yes, and exactly if you want. And under the vessels out. I think that we can switch from swift coagulation. I would like to see. Please, could you? Okay. We will swift to swift coagulation just to see if. Okay, it's almost finished, but just to see if. There is a difference, but I have my setting very nicely. Perhaps I don't want to change now.
And with our last case for today, a 76-year-old male who came for a screening colonoscopy. More than 15 polyps were detected, and they were from different sizes, small and large polyps. So most of the polyps were removed by cold snap polypectomy and EMR. Only 2 remaining large polyps measuring 3 centimeter and 2.5 centimeter, 20 centimeter from the anal verge that needs resection. So I will leave you with Dr. Shayma El Khawli and Dr. Mohammed El Shirbini.
So hello, so this is Shaima Al-Khouli and Mohammed Sherbini from Cairo University. It's our pleasure to be here for the third time in Libano. It's really amazing to see this event is growing each year after the other with a lot of international expertise this time, and each time we learn something. So this is our patient. Here's he's not well prepared. Actually, that's why we are washing so much. His patient had 2 pedunculated polyps in the sigmoid colon. So we are just trying to inspect them carefully to choose which method to resect. So what do you think, Mohammed? Which method to resect?
I think that what we are doing now is a very important step, how to assess the lesion. Because actually you need to clean the colon thoroughly. Because actually we don't worried about the perforation it happened, but we worried about the peritonitis or fecal peritonitis. So first thing and first important thing, we have to clean it thoroughly. After that, we have to assess the lesion and to assess the morphological appearance with Paris classification. And then we have to go to the head of the lesion itself and assess the bed pattern and vascular pattern, how it's invasive or not, using different technique like PLI. Now we are using the gastroscope from Fuji. It's 700 series, 760. Actually, this diagnostic scope with narrow working channel. We prefer to use this scope specifically in low-seating polyps, like lesions in the sigmoid colon or in the rectum.
So it appears,
we are seeing the lesion, Shaima, now. I think it's a 2 pedunculated polyp with long pedicle. What do you think?
Yes, we have 2 pedunculated polyps. The one that is in the cecal side of the sigmoid colon. This is the first one. I think this is the larger one. You can see this is the head. This is the head. It looks like an adenoma.
Yes.
With dysplastic changes. This part is really maybe like high-grade dysplasia up to intramucosal cancer. And this is tubular adenoma. So we have some changes here. And the head, and this is the long pedicle. It's really a long and large pedicle. And then as we move outwards, there is another one. It's also a larger one. It's a large one, but it's smaller than the proximal one. So we will start with this one.
So I think according to guidelines, if we are seeing a pedunculated polyp like this one with a thick pedicle, what do you think, Shaima? I think you prefer to do mechanical compression for this pedicle?
We have a lot of methods in managing the pedunculated polyps. We can start with the EMR. Actually, EMR, you can put some clips first and then cut by snare, or you can use an envelope and then cut by snare. Or sometimes you can inject adrenaline in the pedicle, and then you have to be very careful of the bleeding, and then you close the bed with clips. And for huge pedunculated polyps, when we have that pedicle, very large pedicle, very large head of the pedicle, we have cases like this, me and Mohammed, and we have presented one of our cases in the last DDW about a huge pedunculated polyp in the hepatic flexure. The pedicle was like about 3 centimeters, and the head was like about 7 centimeters, and with an ESD. And actually, it seems to be strange to use ESD in the pedunculated polyps, but there are a lot of reports for the huge. You can discuss this.
Yes, because all of us expecting that this long and thick pedicle had a thick or a central feeding blood vessel, maybe more than one vessel. It can be with wide caliber or large caliber blood vessel. So we refer, because we are using the knife in most of our work, specifically in ESD. So we prefer to cut the pedicle under vision with the knife by injecting the pedicle and cutting the blood vessels. Okay, so we will move back to room 3 and we will lead you again.
في حاجة هنا البيديكل
عليها حاجة.
ما نجيبها easy أحسن.
Okay, then hello again. Then we fight some bleeding out. area. But now we can see, if I show you the lesion, okay, we can see now that there is just some. We can have also some vessels there, but you can see that the clip, the elastic band, help us not to have the lesion falling down. Okay. I use my cap. Which is quite convenient to cut here. We can see the submucosal vessel up, soft. Okay, because it's quite finished, I think I will try to continue. It's really important to do the trimming, I mean to liberate the edge of the lesion and to cut the mucosa to have ops.
Wow.
Okay, another one.
Good vessels.
Allez, soft. Okay.
هذا الفلسل اللي بينزف بس عن
I try to isolate the vessel, but I think it's almost finished, and don't want to have the last bleeding. And now I switch for forced coag, but I think I will use my undercut and you see the cap is quite useful. Just another bleeding point. Okay. You think? Up.
Continue.
Almost. This bridge. Of course, I have vessels. But okay, then we will take some time. I think it's almost. It's separated. Separated. Okay, it's done. Excellent.
Okay.
Thank you. Thank you. Thank you. Thank you. Then, of course, it was grasper. I will take the grasper because. What was unexpected in this case, that's why in endoscopy you always have to be careful and patient. Sometimes you think it's an easy case, but not so easy, as you can see. Thank
لا لا يا شربيني ماشي.
انا
في
ما
واحدة
عملتش اي
تانية
حاجه ما
مضايقاني.
حركتش لسه بحط ايدي.
يلا
اوكي welcome back.
افتح يا علي بقى على الآخر.
Now we are putting into loop on this long pedicle. So our decision according guidelines, we have to do mechanical compression for this thick and long pedicle for this polyp. Actually, we observing the pedicle and we can see a lateral spreading tumor, small lateral spreading tumor on the pedicle itself. So now we are applying the endoloop on this pedicle. You have to be very careful to put the endoloop at the maximum distal part or proximal part of the pedicle. I mean that you have to apply the endoloop to the most near part or near point from the gut wall or the colonic wall. So I think now we are putting the polyp or introducing the polyp inside the envelope, then just to manipulate, open and close and movement throw movement like that, okay, to keep the polyp or the head of polyp inside the end loop. After that, after you making sure that you make it inside the end loop, then you have to pull the end loop back until catching the pedicle of the polyp. Actually, the main challenging point here that this sigmoid colon, it's a floppy colon, it's not stable. Also, as you can see here, many divertically, the sigmoid colon making the lumen is narrow. So also because using the diagnostic scope, you can face some challenging in manipulating the envelope with its handle inside the narrow space or narrow biopsy channel or working channel.
Yes, it's very.
So I think now we came to the base of the polyp or the pedicle. And now we are closing until catching the pedicle.
لا لا يعني مش ضيقة كفاية بتفلت. ما هو بس هو ضيق بس احنا ايه مش عايزينها تفلت.
You have any question from floor regarding the decision? Or anybody have any recommendation on any suggestion?
كمان سنة. طيب ضيق هنا بقى علي. لا بتفلت برضه ضيق كويس ضيق بس دون فاير
يعني ضيق لحد ما يبقى فيه خلاص ريزيستنس.
ايوه انا عايزين ضيق غير سكر. لا 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 مش فاير لا مش فاير
لا دون فاير كلوز لحد ما تبقى
خلاص
فلت.
يبقى احنا هنفتح تاني شويه لغايه ما نوصل للبيز وبعدين نسكر. خلاص ماشي خلاص افتح تاني افتح تاني. عايزه اجيبها من البيز بتاعها لان هي ايه. لا لا لا
لا خلاص
يلا سكر بقى. هي الحركه بس في المنظار الدايجنوستيك. يلا ضيقت كده.
نزقها لجوه كده اتاكد ان هي خلاص.
بس عايزه يكون في سبيس above البتاع. مش متاكده برضه مش متاكده.
شد عليها كده لده. We can apply this one. Then if it's near from the head, we can apply another one near from the
we can change also the
lumen.
position to be on the right lateral position. It can help. But I think we still
But
have a space.
I think this is a good catch. So I don't need to lose this envelope. And if it's still we have long pedicle, we can apply another one near from the wall.
أنا عايزة أتأكد بس.
So we can fire this one.
مش ممكن خلينا قريبين بس من البيز أكتر كمان. عايزة طلعني تاني معلش يا علي. افتح لي سنة. ثواني. امسك كده يا طارق معلش. طيب اقفل كده. سكر يعني.
سكر يعني.
طيب let's see. كويسة كده.
هي نفس البوزيشن بتاعها، ونشوف لو مفيش مساحة كويسة نحط واحد تاني فوق
لا بس انا عايزه اشوف كويس، لو كده نجيبه رايت لاترال وخلاص. بيفلت، هي المشكله. بص بص هو بيفلت. يعني بص الحته دي لما باجي ازق، يعني بص اهو انا بزق اهو، هو بيفلت مننا لتحت.
لا هو انت قافله خالص صح؟ سكرت
على الاخر. لا مضايقه على الاخر.
عم ضيقه مش فاير.
اه
مش فاير. ممكن نغير البوزيشن يا شيرين؟
نغير البوزيشن. ممكن دكتور البنك
البوزيشن والسكوب برضو على فكره برضو مضايق في الحركه.
ما نقلبه يا حسام تعال.
خلي بالك maintain the position. maintain the position.
ماشي، او هاتوا رايت لاترال. خلي بالك بس المنظار ما يخرجش عشان ما ينزعش البيديكل. ها
تيك كير، خلي بالك. شد رجله الاول يعني، شد رجله يا بيوم. خليك انت مع المنظار، مالكيش دعوه بالبتاع. شد رجله يا بيومي، خلي بالك. ايوه لا
ايوه صح.
ولا سيبها لك، سيبها لك نايمه.
سيبها نايمه.
شد وسطه.
احنا شدناها شويه ولا شويه اكتر؟
لا
انا عايزه اجيبه رايت لاترال احسن. لا احنا هنفتح الاندلوب، معلش افتحوا لي خالص عشان ده كده dangerous that we are doing. على الاخر افتحها على الاخر. لا
يا علي
في حاجه في المانيبيوليشن يا جماعه. بس كده شدوا بقى. ايوه
لا استنى. ايه
لا عايزاه رايت لاترال، يعني عايزاه رايت لاترال.
طيب
افتح على الاخر.
طب ادخلي جوه. طيب
ايوه بس كده احنا كده البوزيشن بتاعنا كويس، بس ممكن نجيبه رايت لاترال.
طب نبص الاول كده، ممكن نلاقي ده كويس.
لا مش كويس.
طب بص الاول
ثواني.
كده كويس، كده كويس، كده حلو.
ماشي. بس رايت لاترال احسن. هنقعد بص
ما نعرفش، عايزه نجرب.
لا مش هتنفع. طيب حد يمسك كده معلش. لا امسك على عدلة ايدي بعد اذنك. اهي يلا يا علي. ضيق. ما هو انا سحبته بس هو الحركة بتاعته اتحشر.
هو المنظار ايوه لسه. لا او سي تي، ما انا قلت له هات السي تي.
طيب
بس
ممكن معلش نفتح سنة.
لسه في فوق.
نفتح سنة.
This conference will be presented by Professor Sanem Khoury, who is a professor at Balamand University and
سكر بقى سكر.
gastroenterologist.
سكر كمان ضيق على الاخر. ها
بس
برضه بيفلت. فاير
كده كويس.
كده كويس. فاير.
Thank you شربل. Thank you عبد الله.
الاثنين بقى يعني اسحب عليك واعمل عليك.
Like always, I'd like to thank Organa committee, mainly Dr. Zahir Humani.
وبعدين نسحبها بقى تاني.
أكيد for organizing this marvelous meeting and for
لازم دي تعمل كده.
بقى عشان نطلع
and fellows to
مين شمال
لا لازم
زق
انت
الهوك. خرج الهوك يا
خرج الهوك يا علي.
خرج الهوك يا بيوم.
اسحب بص
خلاص
بص.
خلاص خرج
بس
خرج.
كده.
يلا.
Secondly, I'd like to thank
لا مش مثل الكليب، هو ليه طريقة معينة كده
Stellara and to introduce new things based on the recent
سنير بقى كبير.
DDW.
شفط الهواء عشان انا عايز نفخ قوي.
شفط له بقى في الاخر، ما هو
لا
هو
نفخ جدا.
By
في اكبر من 33.
there will be a case of Crohn's disease.
لو 33 هاتوا هيشتغل ان شاء الله.
And I will finish by
حتى
some
لا
news from
33
DDW
كويس.
2023. This is a case of a 27-year-old lady presented on January 2020 with diarrhea, polyarthralgia, large joints, erythema nodosum on both legs. She had colonoscopy in another facility showing multiple shallow ileal ulcerations compatible with ileal Crohn's disease. An anterior MRI showed evidence of multiple segment ileitis with no evidence of stenosis dilatation. So it was a little bit advanced disease in the small bowel. She was started on prednisone,
العام مش متحضر
60
خالص.
milligram daily with progressive tapering and advised to start biologics. So she presented for the first time to our hospital for a second opinion. And we proposed either adalimumab or
بطني
she chooses adalimumab for financial issues. And she was started on adalimumab.
انت اللي عمال تقولي شفاصي بقى.
انا قلت لك بقى كويس خلاص يلا. يلا هات الاسنان. 33 لا 33.
Resolution of diarrhea, erythema and polyarthralgia. CRP and calpro biochemical were normal. Anterior MRI showed remission, no ileal disease. The bone marrow MRI showed left sacroiliitis. But she suffered from abdominal skin lesion, erythematous plaques and pruritus, and low back pain. She saw a dermatologist. First of all, he considered it was a folliculitis and pityriasis rosea and started her on local treatment. But 2 months later, January 2021, she had an increase in skin lesion. A second opinion dermatology put the diagnosis of diffuse psoriasis on the chest and abdomen and evoked the diagnosis of TNF inhibitor-induced psoriasis, paradoxical reaction to TNF inhibitors. So she was maintained on adalimumab with local steroid treatment. And these are the psoriasis skin lesion on the abdomen, on the chest, and on her back. On March 2021, she had no response to the combination of adalimumab and steroid. She was so started on
احنا كده بعد الحتة دي شايفين الحتة دي احنا عايزين بقى ايه نجيبها بعد
Q8 weeks. On June 2021, it took
السيتنجز
4
بتاعتنا ايه يا شباب؟
months practically
شوية صغيرة.
to have a full remission of skin lesion.
يعني
So I want to talk about the paradoxical effect of anti-TNF. This is an article published in Clinical Gastroenterology
على
and
فكرة
Hepatology
الحاجة
about
بتعدي
tumor
في
necrosis
المنظار.
factor inhibitors in IBD and the risk of immune-mediated inflammatory diseases. There was two large
ده على طرف
cohorts
السكوب.
were studied.
يعني هو
One
دخل بس ده على طرف السكوب.
in Danish cohort. Another one is in France.